Okay, Dr. Shavik.
Okay. Hello and good evening. Welcome to the expert cross-talk on Empagliflozin, multi-mechanisms, multi-indications, and multi-benefits. As we already knew that ESC 2020 was memorable with the pathbreaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology. We should bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to EMPA-REG trial, does SGLT2 inhibitor may be considered as an important drug for HFrEF? For this, let me introduce today's speakers. Today's speakers are Dr. MS Aditya and Dr. Sridevi P. And I'm a moderator, Dr. Shavik. Dr. Sridevi Paladugu is a consultant endocrinologist at Apollo Hospitals and Apollo Medical College, Hyderabad. Madam has several national and international publications in her credit and also received various prestigious awards till date. I welcome Dr. Sridevi in this expert web talk. Our next speaker is Dr. Aditya. Dr. Aditya is a consultant cardiologist, Yashoda Hospital in Hyderabad, and also invited faculty in various national and international podiums. I welcome Dr. Aditya in this expert web talk, and I am handovering the session to Dr. Sridevi to start with her presentation. Thank you.
Shavik, one small request. I don't know. I'm not
Yeah.
able to see myself on the screen. Did anybody in your side make any modification? I'm not sure.
No, sir. No, sir. Tech team, Vinay.
Second, doctor, I'll just check.
Just check it once.
Because my camera is on, I'm not able to see myself there. Should I just...
Sir, because you have shared the screen.
Host has stopped your video. I think somebody has taken control of this thing, I think.
Vinay?
Yes, doctor, it's from the tech team.
Fine.
Okay, fine, fair enough. Can you just switch it on, because I was not able to...
Vinay, can you help, sir?
Yes, doctor.
Are you able to see me now?
No, doctor, not yet.
No, actually, madam has shared the screen, so we won't be able to see actually.
Okay.
So
okay, fine. Yeah, I'm able to hear. I think we can proceed. Yeah.
No problem. That is also fine. The camera is not there. Ma'am, you can proceed. Sorry for the interruption.
Yeah. No problem at all. Good evening, everyone. Thank you, Team Lupin, for this opportunity. And I look forward to interact with the audience and our cardiology colleague also. So my job is to present the endocrine perspective, and we have many drugs in treatment of type 2 diabetes, and most of the treatment options have centered on oral diabetic agents, which increase the insulin availability, like sulfonylureas or gliptins. Then there are drugs which improve the insulin sensitivity, like the thiazolidinediones and metformin. And then there are agents which decrease the delivery and absorption of glucose through the GI system, which are agents like acarbose and voglibose. And we also have these newer agents, relatively newer agents, which increase the urinary glucose excretion, which we call as the SGLT2 inhibitors. SGLT2 is a protein which is there in the proximal tubule of the nephron, and its job is to reabsorb most of the filtered glucose in the nephron. Almost 90% of the filtered glucose load is reabsorbed. And when we have an agent which inhibits this function, it leads to renal excretion of glucose and thereby lowering of the blood glucose. So SGLT2 inhibitors lower the blood glucose concentration by promoting glucose excretion via the urine. And one more important thing about these SGLT2 inhibitors is that because the amount of filtered glucose is proportional to the blood glucose concentrations. If the blood glucose levels are lower, then obviously the filtered glucose is lesser, and thus the risk of hypoglycemias is very minimal with SGLT2 inhibitors, as long as these agents are used alone. If they are used with any other agents, like with any other anti-diabetic agents, the risk of hypoglycemia is higher. But per se, the SGLT2 inhibitors causing hypoglycemia themselves is less compared to the usual anti-diabetic agents that we prescribe. So we have different SGLT2 inhibitors, and there are quite a few agents available in India also, and some more are in the pipeline. So we have dapagliflozin, remogliflozin, canagliflozin, and empagliflozin. Let us look into a little bit detail about these agents. The dosages of each of these molecules is different. Empagliflozin 10 mg and 25 mg, dapagliflozin 5 mg and 10 mg, canagliflozin 100 mg, which is widely available in India, and 300 mg. So usual peak concentration is at around 2 hours after administration of the drug. You can see the availability, oral bioavailability of each of these agents is between 60 to 80%. And these agents are different, slightly different with respect to the elimination. Empagliflozin elimination is almost equal between hepatic and renal, whereas dapagliflozin is more heavily reliant on the renal excretion to the extent of 80%, and canagliflozin around 70% is excreted via the liver. So there is something called as the selectivity of SGLT2 inhibitors over SGLT1. So SGLT proteins are which bring about changes in the glucose absorption in the GI system or in the renal. SGLT1 is expressed in the gastrointestinal system. And if you have a lesser selective SGLT2 inhibitors, that is, it acts both on the SGLT1 and the SGLT2, then you might have an increased amount of GI adverse events. So that is the point about SGLT selectivity. So you can see the selectivity of each of these agents. And we actually had, I think there is one more gliflozin, which is called the sotagliflozin, which was used in type 1 diabetes, which was both the SGLT1 and 2 inhibitor. So the glucose excretion per day in grams is around 70 to 80 for both these agents, empagliflozin and dapagliflozin, and is around 119 for canagliflozin. So the next few slides are about phase 3 trials with empagliflozin. So in the monotherapy, there is a HbA1c reduction of about 0.7% compared to the placebo. That is what is expected with any of these SGLT2 inhibitors. And when it was added to any of the other agents as an add-on drug to metformin or pioglitazone or metformin plus sulfonylurea also, the HbA1c reduction was around 6.6%. Then one of the beneficial effects of SGLT2 inhibitors is the weight reduction. Whenever we have these anti-diabetic agents, we are worried about weight gain, because if the patient gains weight, we need more higher dosages of each of these agents to control the blood glucose levels. And most of the traditional anti-diabetic agents like sulfonylureas or insulin or pioglitazone have all disappointed us with respect to the weight. That is, they do cause weight gain. And the gliptins, most of them are weight neutral. The only drug which was available for quite some time was metformin. And then we had GLP-1 analogs and now SGLT2 inhibitors, which do cause a significant amount of weight reduction. You can see in the monotherapy, up to both the dosages, 10 mg and 25 mg, both the dosages cause around 2 kgs weight loss. And when it is used as an add-on drug to either metformin or pioglitazone or metformin plus sulfonylurea also, this beneficial effect of weight loss of around 2 kgs is persistent. The other advantage is the reduction in systolic blood pressure to the tune of around 2 to 3 mmHg. And similar is the diastolic blood pressure reduction also. So this is the 12-week ABPM study of empagliflozin treated patients with type 2 diabetes and hypertension. You can see that at baseline, almost all of these patients, around 270 in each of these groups, had similar systolic blood pressures. And by around 3 months or week 12, there is a significant reduction in the systolic blood pressures of the people who are on empagliflozin. So one might have to reduce the antihypertensive dosages after about 2 months of starting SGLT2 inhibitors. As I was saying, the reduction in blood pressure is similar for systolic blood pressure and also diastolic blood pressure. And usually the changes are seen by the end of 2 months or so. Then one of the important features of empagliflozin is the changes in the lipids. You can see that there is a significant reduction in the triglyceride levels. And if you look at the LDL and HDL or total cholesterol, all of them are slightly increased. But again, the ratio of LDL HDL is actually the same or even reduced. So a quick 1 or 2 slides about the adverse events of SGLT2 inhibitors. We all know that because urine glucose is increased, they are naturally at an increased risk of developing genital infections or urinary tract infections. And the genital infections with 25 mg empagliflozin were around 268 in number compared to the 41 in the placebo group. Genital infections are quite common when we tend to use these agents, but they are not very severe. Usually they are mild, and most of the times they are treated with simple agents. Then the serious side effects of urosepsis and pyelonephritis, the numbers are not that significant, but we do see urinary tract infections also. But genital infections are much more common. If you look at the hypoglycemias, the severe hypoglycemia effect are almost same as the placebo. So with respect to hypoglycemia, we do not have much to worry about. So during the different trials of empagliflozin, serious adverse events which have led to discontinuation of the drug have been very few in number, and most of these have been comparable to that of placebo, with both 10 mg empagliflozin and with 25 mg empagliflozin. Now coming to the empagliflozin CV outcomes in patients with type 2 diabetes. So after the rosiglitazone debacle, FDA had made it mandatory that every anti-diabetic agent which comes into the market has to undergo rigorous CV safety trials. And that is the reason you have so many CV safety trials of each of these agents, which we have been hearing in the past decade. And the CV safety trial for empagliflozin has been EMPA-REG, which has come out in 2015. And it was a trial which was done in around 7,000 patients, and they were randomly assigned to either 10 mg empagliflozin or 25 mg empagliflozin or placebo, and the empagliflozin was pooled for analysis sake. Both the 10 mg and 25 mg patients were pooled and compared with the placebo. So the primary outcome was death from CV causes or non-fatal MI or non-fatal stroke. Out of the 7,000 patients, on the whole, the empagliflozin group consisted of around 4,000 odd patients. In them, around 490 events were seen, and compared to the placebo, it was 282 out of 2,000 patients. So it was around 10% events for the empagliflozin group compared to the 12% of placebo. And there was no significant difference in the MI or stroke in both the empagliflozin group and in the placebo group. So the death due to CV causes was around 3.7% for the empagliflozin group compared to 5.9% for the placebo, which was around 38% risk reduction. The important outcome of this trial was reduction in the heart failure and reduction in the hospitalization with heart failure. If you look at this animation, wherein you can see that the 3-point MACE, CV death, and non-fatal MI are all favoring empagliflozin. Hospitalization with heart failure was around 2.7% versus 4.1%, where there was a 35% risk reduction with hospitalization due to heart failure. And death from any cause was 5.7% with empagliflozin compared to 8.3% with placebo, which was around 32% risk reduction. So after the outcome of this trial was published, there was a significant chatter and change in the way the SGLT2 inhibitors were looked at. And now I believe the cardiologists are very much interested in SGLT2 inhibitors as much as we are, if not more. Then it was the harbinger of SGLT2 inhibitors being used or even considered in treatment of heart failure, in the long-term treatment of heart failure. So along with the standard of care, these secondary agents could be used to reduce the heart failure, hospitalization, or CV death in patients with type 2 diabetes with baseline heart failure. So slide about the renal outcomes. SGLT2 inhibitors surprisingly also had one of the other significant benefit out of these trials, where they have shown that there is a decrease in the progression to macroalbuminuria, a decrease in the worsening of nephropathy, and this point was further confirmed by the various other SGLT2 inhibitors like Empagliflozin also, which has shown that these SGLT2 inhibitors are useful in the microalbuminuria patients and in the initial stages of CKD. The late stages of CKD, anyway, we cannot use the SGLT2 inhibitors, say when the eGFR is less than 30, obviously. The SGLT2 inhibitors have lesser role because their mechanism of action is very much inhibited, and the beneficial effects will not be seen. But in the initial stages where progression to the stage 3 and 4 can be avoided by using these agents, wherein there is a significant change in the albuminuria and reduction in the macroalbuminuria. So now, how early is this benefit of empagliflozin seen with respect to heart failure? We'll hear more about the CV benefits of empagliflozin, but it can be said that it was quite early that they have seen these benefits. Then coming to, how is it that these SGLT2 inhibitors can bring about such good CV benefits? So, as we were discussing, it reduces the blood pressure. So, a number of mechanisms have been proposed for these varied CV benefits of SGLT2 inhibitors. It causes osmotic diuresis. So it reduces the preload on the heart. When we were in the initial MBBS students, we used to have this preload, afterload. So by promoting osmotic diuresis, it reduces the preload, and it has various vascular benefits, wherein it improves the endothelial function and also promotes vasodilation. So it reduces the afterload. It improves the myocardial metabolism and improves the cardiac efficiency. It reduces the cardiac fibrosis. It also reduces the sympathetic nervous system activity. We all know that hyperactive sympathetic nervous system during the time of heart failure is associated with bad prognosis. In the long term, because of the reduction in weight, reduction in the visceral adiposity, and a reduction in the oxidative stress, it leads to beneficial effects in the cardiovascular system. So maybe lot to research about and lot to ponder about how these SGLT2 inhibitors cause such good beneficial effects. I think it is one of the last. Okay, there are a few more slides to go. So if you look at the mainstay of treatment of heart failure, the few mechanisms in which they treat these patients with heart failure is to increase the natriuresis, reduce the preload, afterload, reduce the interstitial edema, and improve the cardiorenal physiology. If you can see, of all the initial agents, which are usually ACE inhibitors or ARBs, ARNI, and beta blockers, along with diuretics, most of these effects are also seen with SGLT2 inhibitors. And hence, I think they are here to stay with respect to not only with respect to type 2 diabetes treatment, but also with respect to heart failure treatment. So this is just a bird's eye view of various CV safety trials of each of the anti-diabetic agents. And the red are all the CV safety trials of SGLT2 inhibitors. And you can see that EMPA-REG was one of the first CV safety trial, which led to this surprising but very much beneficial information about the SGLT2 inhibitors, which was later on proved by various other agents also. And this has led to the change in the ADA-ESD guideline, which was that previously we had the first step, which was to use lifestyle modifications plus metformin. And then we had a choice of various agents which we could use, which can be sulfonylureas or thiazolidinediones or gliptins or GLP-1 or SGLT2 inhibitors. But now, after metformin lifestyle changes, the guidelines say that we need to look at those people who are at significant cardiovascular disease risk, assess them with respect to the cardiovascular risk, and then choose the agent. If they are at significant risk of CV disease, it's better to choose GLP-1 receptor agonist or choose SGLT2 inhibitors. And yeah, this is the change which the SGLT2 inhibitors CV safety trials have brought in. Thank you.
Yeah, ma'am. Thank you for the very good introduction to this topic. I don't know. I'm not able to see myself on the screen, but I think you can hear me, I guess.
Doctor, it seems your virtual cam is not working.
Okay. Let me.
Besides, besides the mute option of the camera,
okay.
there's a small arrow button.
There is a stop video, mute my audio. Should I rejoin the thing? Or?
No, doctor. When you joined it, it was perfectly fine.
Yeah.
It seems the camera.
I'm able to see that that light on that camera thing. Just a minute. Just a second.
Doctor, besides just start
okay. Should I share my PPT so that maybe that will come? I'll just see whether that is good.
Yes. Doctor, actually, your start video option. There's a start video option, and besides that, there's a small arrow key.
Just you are able to see my screen?
Yes, doctor, it's perfectly fine.
The screen is fine. Yeah. So now you want me to just a sec. Yeah. So here I have stop video is coming, and that's all. I mean, the video is actually running. I mean,
it's running. It's just the camera setting is changed, doctor.
Yeah.
So there are two options, right? One is unmute and one is stop video. And in that stop video option, there's a small arrow inside. Okay. When you click on the small arrow,
just a second. I'm not seeing any. 1 minute. Let me just. So one is PC camera. Choose virtual background video settings.
The PC camera option, doctor. Which one is the chosen?
I don't know. It's good to me. Did not see any video. 1 second. Yeah, should I just get along with the presentation? Is it okay?
Yes, doctor. It's perfectly fine.
I think it will save us some time. Okay.
Yeah. Can you make the presentation on full screen and start?
Yeah, I'll do it.
Okay, doctor. Perfect.
Yeah. So from the cardiology, like Madam has given a very good introduction to this subject, and I'm sure as we have evolved through our medical college days, these sort of questions. I mean, of course, I'm probably these questions used to come to us as the future directions of medicine. We used to have a fourth paper in MD General Medicine where we have a future direction. So we used to see all the GLP analogs, SGLT2. So we used to write them as a future perspective. Now I think life has turned a full circle, and now they're the present practice. So the point is, I mean, this is one drug which has actually been taken over in the sense more in the heart failure subject rather than in diabetic control. But then because the endocrinologist is the focal point of contact for a patient, and these are the, I mean, they actually see several patients at high risk of developing heart failure or renal failure. So at that point, I mean, the addition of these drugs makes a lot of sense. Now, what makes this group of drugs special is they're actually their unique mode of action. Now, we as cardiologists struggle to lose sodium in the body. I mean, we keep telling people to keep taking less salt because it leads to hypertension and all of the consequences of vascular damage. But it's a big struggle to get people to lose sodium. So this group of drugs actually are most cardiology friendly because we end up losing sodium because almost there's an increase in urinary excretion of 30 to 60% with the use of these drugs. So that that makes these. I mean, whatever they do, all the pleiotropic effects and all, I'll forget about that. I'm just focusing on what they actually do. So the sodium loss, according to me, is the forme fruste of these drugs, and that's why the cardiologist enters the picture. No, of course, it's a novel way to lose glucose. All the existing strategies were trying to modulate insulin release or trying to increase the sensitivity or push the insulin or increase the sensitivity. So that kind of actions were there. But here, this is actually truly losing insulin. So because of this complex multimodality benefit, widespread cardiovascular benefits have been seen. Incidentally, I mean, as looking for CV safety, actually turned out to be a CV protecting agent. I mean, that's a pretty unique thing because the earlier, like Madam said, with the glitazones, increased incidence of cardiovascular events was a put off, and the FDA started including CV safety also. But then, if you look at this group of drugs, when they were looking for CV safety, they actually found that these drugs were actually cardioprotective. So why they're important is, one is, I mean, the various interactions with the cardiovascular system is, like Madam said earlier, blood pressure lowering. This, I think, is the most quantifiable and the most useful effect of the SGLT2 inhibitors. We know the blood pressure lowering is significant, it is sustained, and then this probably accounts for a vast majority of their cardiovascular benefits. So what the blood pressure lowering does is it actually improves the arterial coupling with the heart and then improves the efficiency of the heart. The antihypertensive effect is also pretty profound. I mean, this can be compared with thiazide diuretics, or in fact more than thiazide diuretics. And this is a very objective finding with the use of SGLT2 inhibitors. So like Madam said, I think we need to make some dose adjustments to account for these drugs. The second is the diuresis and the natriuresis. I was talking about this loss of sodium that happens through urine, which is a very useful thing for patients of heart failure. Not only this, actually, because of the osmotic pressure within the proximal renal tubule, we have a lot of diuresis also happening. Now, this is a kind of a balance that is very useful in a heart patient. Not only that, we also see that there is an increased incidence of the usual diuretics cause both natriuresis as well as intravascular volume depletion as well as interstitial volume depletion. In comparison, the SGLT2 inhibitors cause more interstitial volume depletion while preserving the intravascular volume. Now, this is useful because once intravascular volume also depletes, there's an activation of the compensatory mechanism. So, this is a novel way of losing water and sodium at one go. Now, if you look at the cardiac energy metabolism, you see, we all know that the heart feeds on free fatty acids as its primary source of energy. But then in a diabetic state or in patients of heart failure, this oxygen dependent system or because of mitochondrial dysfunction or lack of adequate mitochondrial function, the energy balance is shifted to glycolysis, causing intracellular acidosis. Now, what happens as a consequence of this is it sets off a several cascade of events that lead to worsening of cardiac metabolism. One of the things the SGLT2 inhibitors do is they increase with their action on the adipocytes, they increase ketone generation. Now, ketone, though, is not a very efficient fuel for the heart, it is an additional fuel for the heart. So the heart has got multiple sources of energy through which it can actually work. So in a way, the ketogenesis that is with SGLT2 inhibitors actually adds another fuel to the heart, improving the energetics of the heart. Now, also inflammation. Now, inflammation we all know is a potent driver of atherosclerosis, of heart failure, and we consider heart failure as a syndrome now. One of the issues of inflammation is, of course, the hyperglycemia itself leads to inflammation because that leads to this macrophage inflammatory response, and the novel inflammasome, that is NLRP3, is also downregulated with the use of SGLT2. So inflammation, a key issue in heart failure, is also downregulated by the SGLT2. Now, we also know that this ketogenesis, the ketones that are generated, that beta hydroxybutyrate, is actually instrumental in decreasing the activation of this NLRP3. Other thing is the weight loss. Like Madam had rightly pointed out, this is one drug in diabetic medication, which leads to, I mean, probably other than metformin, which leads to a significant weight loss. And now in a heart failure patient, this is we have several utilities of having heart weight loss. Now, improving glucose control, of course, like any oral hypoglycemic agent, we have a HbA1c response of up to 1 to 1.5%. Also, there is some inhibitory action on the sympathetic nervous system, a good effect on preventing the cardiac remodeling. And also, these inhibitors are known to prevent ischemia reperfusion injury, primarily through their actions on the calmodulin kinase 2 activity. And then these inhibitors are known to have an action on the sodium hydrogen exchanger, decreasing the intracellular sodium. And probably like earlier the slide was shown where they also have some role on the SGLT1 inhibition, which are expressed on the cardiac myocytes. Now, what exactly this inhibition does, we don't know, but it is proven. It is postulated to be beneficial. Also, a reduction in the uric acid levels, an increased autophagy and lysosomal degradation. So we know that there is a catabolic state. I mean, the body, this whole thing simulates the catabolic state. The loss of glucose to the body is sensed as a catabolic state. There is increase in autophagy and lysosomal degradation. So this also leads to improved heart failure outcomes. Another important thing is the EPO levels. The erythropoietin levels are increased with the use of SGLT2, and there is an increase in the hematocrit. Various mechanisms are postulated for this. I'll go on to show them. There's an increase in the provascular progenitor cells and also decrease in oxidative stress with the SGLT2 inhibitors. So there's a wide spectrum of action of SGLT2 inhibitors so far as cardiovascular disease is concerned. So I was talking about remodeling. Once an injury occurs to the heart, a trigger is set off, and then this leads to several actions like left ventricular hypertrophy, increase in inflammation, extracellular matrix remodeling. So all this leads to a thickening of the myocardium, a dilatation of the heart. Now, with the use of SGLT2 inhibitors, substantial amount of remodeling can be reversed or prevented. So that is one aspect of SGLT2 inhibitor usage. The cardiac energetics I just told, in an energy depleted state or in a diabetic patient, the glycolysis starts feeding into the energy matrix of the heart, But then once we use an SGLT2 inhibitor, the metabolism is also shared partly by the ketones. So this increase in metabolism improves the myocardial energetics. So I was just talking about all these mechanisms that are triggered off in heart failure and how SGLT2 inhibitors actually act on in improving the outcomes. We can see that the SGLT2 inhibitor downregulates the sodium hydrogen exchanger, decreasing intracellular sodium. Also decreasing the kinase, calmodulin kinase. So again, decreasing ischemia reperfusion injury, because a lot of these patients keep having ischemic events and then reperfusion, and that cycle worsens the cardiac condition. So again, autophagy is increased. The down regulation of the inflammasome is there. Improved renal function is there. Increased provascular progenitor cells, increased erythropoietin, decreased sympathetic nervous system, improved energetic. So these are all beneficial in a patient of heart failure. So I was talking about the increased erythropoietin levels. So now this is postulated to be because of various mechanisms. That is the action of SGLT2 inhibitor on the afferent arteriolar tone, and then the increased ketone genesis leading to increased EPO, decreased oxidative stress, decreased renal blood flow, and increased sodium in the distal tubule. All these triggers lead to increased erythropoietin in the body. Now, the increased erythropoietin leads to increased iron utilization, good oxygen delivery, and then increased oxygen delivery to the heart, decreased LV mass, and decreased inflammation. So this is an important mediator so far as the heart failure and the kidney interaction is concerned. So, like previously we discussed, diabetes is a state of hyperfiltration because of the dilatation of the afferent arterioles. Now, because of this, there is increased proteinuria. Now with the use of once the increased sodium is detected in the proximal tubule, and afferent arteriolar constriction is triggered off, decreasing the intraglomerular pressure and also proteinuria. So this is postulated to be the mechanism of renal protection with the SGLT2 inhibitors. So again, I was talking about this the action of SGLT2 inhibitors on the intravascular and the interstitial volume. So if you look head to head, the SGLT2 inhibitors are known to have or cause lesser intravascular depletion and more interstitial volume depletion. So these are the other actions of SGLT2, like I was showing, I was talking about earlier, the inhibition of the sodium hydrogen exchanger. So ultimately, this leads to a decrease in the intracellular sodium. Now, intracellular sodium, when it's increased in the cell, actually again gets transported out at the cost of increased calcium within the cell. So this leads to an increased arrhythmogenicity in the cardiac myocyte. So these are all. This is a summary of all the ways SGLT2 inhibitors, impact heart failure prognosis involving the vasculature, the whole body, kidney, and the heart. This is a summary of various ways these inhibitors go on to protect the heart. So this is the data that is already available to us so far as the impact of SGLT2 inhibitors on the cardiorenal benefits are concerned. Whether it's EMPA-REG, whether it's Canvas or the declared TIMI, and then with the Vertus CV. So the evidence is pretty strong. One point of interest is the heart failure itself. You see, I think Madam also would have appreciated, probably with the use of statins and more awareness of coronary artery disease, the incidence of coronary artery disease is actually probably taking a downward trend, but then the heart failure incidence is actually going up. Now, this is multifactorial, either because of diabetic milieu or a mixture of atherosclerosis and diabetic milieu or hypertension. So various factors are there. So we would be looking at heart failure in the future as more of an issue rather than coronary artery disease. This was emphasized by Dr. Braunwald almost 10 years back about the future of medicine. So again, we see the high rate of heart failure is also seen in patients of diabetes. This is present either with or without coronary artery disease. So the heart failure outcomes in glucose lowering agents, if you look at it, the strongest evidence is there with the SGLT2 inhibitors with very significant hazard ratios. So the outcome, like Madam has said, I will not discuss much about the EMPA-REG because already it's been discussed. So again, one important point about the dissociation curve. Now, if you look at this, the dissociation curve in most of the studies started after a year or so. But then if you see the dissociation curve, it almost starts very quickly after the institution of therapy. This is an important point because the intravascular changes or the renal changes that occur because of the use of SGLT2 inhibitors almost immediately affect the cardiovascular outcomes. And with time, the separation is maintained and it persists. So this is a very strong point according to me. That is the almost immediate impact of the usage of these drugs in improving cardiovascular outcomes. So again, the guidelines reflect the existing data. So now we have to consider the usage of at patients of high risk of having cardiovascular risk. Now probably SGLT2 inhibitor would be a choice agent as compared to metformin, which was the gospel truth till now. So the same thing goes with the ACC-AHA also, but then they are more reserved. They still stick to metformin as a first line therapy. So the Emperor heart failure studies, because this is hot of the oven, and that was discussed in this ESC 2020. Of course, this was all a virtual session, so people didn't pay much attention, according to me. So again, this is a class of patients of heart failure who are actually pretty sick. So the Emperor reduce dealt with EF less than 40%, and then high BNP levels for moderate LV dysfunction and low BNP level. I mean, relatively low BNP levels for lower. The idea is to incorporate as many sicker people into this study as possible, so that patients who are at high risk of having future events are actually randomized in this trial. So then, as usual, there's a run-in period of around 28 days, followed by randomization. So a widespread study, and then so again, these are all these mechanisms of cardiovascular benefit I have already discussed. So the idea is to know whether there's any meaningful addition, and all these patients were receiving very good other disease-modifying agents like ACE inhibitors, ARBs, all the standard therapies, ARNIs. So this is that way it's a very modern trial because it incorporates the state-of-the-art medication. So the point is, we are expecting an event rate of almost 15% in these patients. So this is a high-risk subset of patients, and the results were published in this August 29th edition of the NEJM. So again, if we look at this this trial, the emphasis was on heart failure irrespective of the diabetes status. So again, like I initially said, this group of drugs is gradually getting shifted into the heart failure treatment rather than only for the diabetic treatment alone. So this is the general outline of the trial. So EF less than 40%, and then again these patients are graded into people with EF less than 30% and proBNP of more than 600, or more than 1000 and EF of 31 to 35, and more than 2500 for EF more than 35%. So idea is to categorize them into higher risk subgroups. So predominantly it's a Caucasian population with a GFR of mean GFR of less than 60 was there in 50% of patients. So this, according to me, is a high risk subset of patients who have a depressed LVEF, who have a low GFR. A lot of them are receiving device therapy, at least 30% of them on ICDs and CRTs. So the principal primary outcome of CV death, heart failure hospitalization, was significantly reduced in the empagliflozin group, and the heart failure hospitalization as well as the CV death was not significantly different, but heart failure hospitalization was significantly different. So again, if you look at the secondary endpoint of renal protection, there was a 50% lesser incidence of renal events in this in this group over a period of 3-year follow-up. Again, I emphasize the point that the separation of in cardiovascular hospitalization outcomes happens very early with the institution of these drugs. So there is no time delay at all. We expect, of course, with also the DAPA-HF study and Emperor reduce trial, that they will be the SGLT2 inhibitors will form part of the heart failure paradigm. So we see significant number of reduction of hospitalization for heart failure events, and also a reduction in the all-cause death, which is a strong parameter, and also the slope of GFR. So the slope of GFR is much better in patients on empagliflozin, emphasizing their renal protection role. So if you look at other things like the reduction in the NT-proBNP is also significant. The improvement in the hematocrit, I was talking about the increase in EPO and the reduction in heart body weight and the systolic blood pressure. So again, the reduction of heart failure, whether it's the first or the recurrent one. And then these are the issues with the serious adverse events. So the serious adverse events related to cardiac disorder are lesser. Related to worsening renal function are also much lesser. Now, the other things that are discussed, and partly Madam had covered the some of the adverse events. These are also compared across both the groups. If you look at it, it is a genital tract infections which are more as compared to the urinary tract infections, which are almost similar. So this point is important because people tend to think that it is a I mean, people don't really understand the difference between two, and most of these genital tract infections are actually milder in nature. The other fear of SGLT2 inhibitor is the ketoacidosis. Again, it was not significantly different. Hypotension also was same in both the groups. Bone fracture, because of the because of the high levels of parathyroid hormone or bone mineral deposit disbalance, the incidence of bone fractures was supposed to be high with the use of SGLT2 inhibitors, but that was not significantly different. And also the incidence of lower limb amputations. Again, this was a concern. It was thought that osmotic diuresis leads to decreased intravascular volume, increased hematocrit, and sluggish blood flow, and causing increased incidence of lower limb amputation, but this was not to be seen. So, like I was saying, all-cause mortality is reduced, which I think is a very strong point in any trial. The renal outcome is better, and heart failure hospitalizations have subsequently reduced. With a slightly lesser, in patients of diabetes, the HbA1c levels significantly reduced. Systolic blood pressure is reduced, but hypoglycemic events were not. So even in patients without diabetes, hypoglycemia did not occur. So we understand now that empagliflozin is superior to placebo in improving heart failure outcomes. Benefit is primarily driven by reduction in heart failure hospitalizations. There was also benefit in renal outcomes. So this is an important trial that also mirrors the findings of DAPA-HF. So earlier I was saying, though these drugs were introduced as diabetic management, now I think they will have a lot of role in heart failure management. Probably they'll have important recommendations in heart failure management guidelines. So these mechanisms of cardiovascular benefit are already discussed. So the other trials that was discussed in this ESC was the Embody trial, and then the effect of empagliflozin as an add-on therapy on tubular potassium concentration gradient patient with type 2 diabetes, and the effects of empagliflozin on arterial stiffness, endothelial function. So these are all the various places where empagliflozin is being studied. So again, to emphasize the safety points, one is the awareness about urinary tract infection or genital infections, the bone density or the increase in hip fractures that was initially reported, but I think I would watch these patients more keenly. Then the lower limb amputations, peripheral vascular disease remains a concern. Of course, these we have to, but we should not deny our patients the benefit of these wonderful drugs. Diabetic ketoacidosis, I would like to discuss with Madam what is her take on this. Because some endocrinologists have expressed some fear about this complication. The cancer incidence, that is increased female breast cancer and male bladder cancer. Again, this was not statistically proven, but this was added as a warning under FDA guidelines. The risk of hypoglycemia, I think it is marginal, not much. One is acute kidney injury, because we know that there's afferent arterial constriction, decrease intraglomerular pressure. So the impact on renal function is one of the important things that sometimes may be of relevance in the management of heart failure. Thank you.
Thank you, Dr. Madhav and Dr. Sridevi, for your wonderful presentation. There is a question for Dr. Madhav. Sir, can I?
Yeah, please. Yeah.
Okay. One question from the audience is, which SGLT2 inhibitor is best for CV, for cardiovascular protection, EMPA or DAPA, as per your clinical feedback?
Yeah, so the point is we can only go by the data that is available to us. I mean, that way the data for DAPA and EMPA is quite strong. Though, of course, the class effect and the individual drug effects, I mean, one can always postulate that theory. But then till we have data, I would support the use of either of these drugs in these cases.
And moreover, there is a question for Dr. Sridevi. Ma'am, actually, in diabetic patient, after this trial, can we can we consider that EMPA is better than metformin?
Why? I mean, what led to this conclusion?
Something like this, that after this EMPA-REG trial, because Empagliflozin shows a better result, diabetic patient also. So the question, something is like this from the audience, that can we compare EMPA with metformin after this EMPA-REG trial, that EMPA is better than metformin if we initiate early?
So I wouldn't go into a direct comparison of saying that EMPA is better than
the
metformin.
real world, some clinical, your clinical experience actually, something like that.
Yeah. So, of course, lifestyle modifications and metformin remain the core to type 2 diabetes treatment. Metformin is something which is advised to all the diabetic patients unless it is contraindicated. All the guidelines also support this statement, wherein unless there is a renal cause of concern, or there is any other chronic liver disease, or there is a significant metformin intolerance, metformin should be prescribed to each and every type 2 diabetic patients, which cannot be the same statement. We cannot make the same statement with regards to SGLT2 inhibitors. We have to choose the patient profile, which will be a relatively obese patient who is not prone for urinary tract infections, not the very old postmenopausal ladies who are prone for urinary tract infections and genital infections, in the very old postmenopausal ladies who are 65 or 70 plus. It becomes a problem. And in type 1 diabetic patients, or in LADA patients, wherein we tend to look into insulin or sulfonylureas more rather than SGLT2 inhibitors. So a generalized statement saying EMPA is better than metformin would not be true. Yeah, but both have their benefits in terms the similarities being that there is plus with of these agents, and I mean, maybe the similarities end there.
Okay. Thank you. There is no more question. So we're concluding the session, madam. Thank you, Dr. Sridevi and Dr. Aditya, for a wonderful presentation and sharing your experience. And on behalf of Lupin, we thank you both, and we'll see you in the future. Thank you very much.
Thank you, sir. Thank you, ma'am. Yeah.
Thank you.